All. This is Dr. Mubin Sayed from drbeen.com. Welcome to one more show. So the discussion today is about the neuropathic pain, which causes sometimes regional, that is one part of the body, and sometimes throughout the body, the feelings of burning sensation, pins and needles, hot and cold, crawly sensations. Even it can produce physical changes in the tissues where the muscles or joints can swell up and become painful. The skin can become red and bluish. It can have a marbled appearance on it. It can have red appearance on it, and it can even become dry. Majority of the time, there may be, if it is confined to a tissue, it may be local tissue injury. It may be blood vascular issues. It may be diabetes. It may be nerve compressions. It may be local nerve damage. However, when it is systemic, when it is throughout the body, then in an important pathology, that is sensory ganglion neuropathy, must be considered as well. It could be vascular system, which is also throughout the body, and it can be sensory ganglion problems too. So in today's discussion, we're going to talk about sensory ganglion pathologies. So let's first look at the references, and then we will look at the pathologies. I'm using OBS today and a little less skilled with it. So my apologies. So here, first of all, this is drbeen.com. Over here, we have a lot of medical lectures. So if you would like to have more medical lectures, please get access to this. Plus the pain series with this one lecture as well. That series is actually being uploaded to drbeen.com, and we have CME and CEs there as well. Although the link that is in the description does not include CMEs, but you can go to drbeen.com and look at plans for CMEs too. So with this quick note, let's look at some of the references, and then we'll go to my drawings. So here, this is Mayo Clinic complex regional pain syndrome. It's actually not very clear for what causes it, but look at the symptoms here. Continuous burning or throbbing pain, usually in the arm, leg, hand, or foot. So this is one region, one part of the body. Imagine that this can happen to some people throughout the body as well. Sensitivity to touch or cold, swelling of the painful area, changes in skin temperature, alternating between sweaty and cold, changes in skin color ranging from white and blotchy to red and blue, changes in skin texture, changes in hair and nail growth, joint stiffness, swelling and damage, muscle spasms, tremors, weakness, decreased ability to move the affected parts, etc. Then look at this study, and the links are in the description. Neuropathic pain associated with COVID-19, a systematic review of case reports. So if you see over here, there are a beautiful collection of case reports where neuropathic pain is experienced by the patients. What I wanted to show you here, again, every one of these studies can take an hour to discuss, but these are my references or evidence that I want to bring to the table. When I do the discussion, you are aware that there are these evidences. So here, this is supported by viral genome studies on peripheral neuropathy, inflammation of the peripheral nerves, and ganglia. So today's topic is ganglia. That is why I'm having you focus on the ganglia. Peripheral nerves and ganglia, as well as tissue damage, causes the development of pain. Of course, I haven't yet presented the definition of neuropathic pain. I would do that. First, the references. So here, SARS-CoV-2 or COVID, causing sensory ganglion and peripheral nerve damage, resulting in neuropathic pain. Then, functional anatomy of the sensory nervous system. This is a beautiful article about how the sensory system and its anatomy is. I'm going to leave this on. Then look at this one. Tissue resident M2 macrophages directly contact primary sensory neurons in the sensory ganglia after nerve injury. So this is the role of macrophages that we would discuss. Here is another study. SARS-CoV-2 airway infection results in development of somatosensory abnormalities in a hamster model. And if you see here, they are looking at this phenomena was associated with a durable gene expression signature in sensory neurons. What they're saying is that in case of sensory SARS-CoV-2, in the mice model, which the mice that developed neuropathic pain, they actually had their sensory neuron gene structures changed and developed this chronic neuropathy. And then they have this drug over here as well. ILF3 blockers are used in cancer therapies. However, ILF3 blockers are able to go to the sensory ganglion and reduce the transcription of messenger RNAs there, that may be the COVID messenger RNA, and block them. Then here is another study, neuropathic symptoms with SARS-CoV-2 vaccination. And in this one, what I would like you to look at is, if you see here, 100% of the people who are part of the study reported sensory symptoms comprising severe face and or limb paresthesias. Paresthesia mean abnormal sensation. And 61% had orthostasis, heat intolerance, and palpitation. Orthostatic postural hypotension, meaning palpitations when you stand up, with heat intolerance. And then what I would like to show you here is another important part, and that is what pathology may be at play. And so they write here, if you see this part, all our patients had neuropathic symptoms, but objective findings of small fiber neuropathy were present in a few patients only. So in this study, they're saying that we had a number of people with the neuropathic pain. However, not everyone had small fiber neuropathy. Why are they talking about it? Because many times doctors actually start suspecting that there is a small fiber neuropathy. So here they're saying not everybody had it. So then what was the problem? So they're saying not all patients with autonomic dysfunction had abnormalities on skin biopsy. In studies of mouse sensory ganglia, small fiber neurons preferentially display the ACE2 docking proteins. So our sensory ganglia, which I will discuss a little later today, their neurons have ACE2 on them, consistent with potential predominance of small fiber neuropathy. Since all SARS-CoV-2 vaccines encode the spike protein, listen to this carefully, since all SARS-CoV-2 vaccines encode the spike protein, anti-spike protein immune responses may link post-COVID and post-vaccine syndromes. Although the spike protein might interact directly with neurons to mediate the sensory symptoms, anti-idiotypic antibodies to the spike protein immune complex also binds to ACE2 receptor. And I have done this discussion in detail. There was a paper by Dr. Bill Murphy, who has been on this channel many times. His paper was about anti-idiotype antibodies, which can actually bind to ACE2 receptors just like spike protein can. And here you're looking at a study where they're talking about autonomic syndrome after vaccination, which would include not just the autonomic. If somebody has sensory ganglionic problem and they have autonomic issues, then they might have sensory problems as well. And here the pathology they're thinking could be the anti-idiotypical antibodies. Now, anti-idiotypical antibodies could occur after vaccine or after COVID as well. In case of COVID, there can be direct spike protein as well. So I wanted to show you this. Then there are some other studies. How is peripheral injury signal to satellite glial cells in sensory ganglion? So I'm going to just close these other ones. I would go now and start the actual discussion. So I hope so far everything is okay and the audio is okay and the video is okay, because this is a new setup and I'm still learning to work with it. Okay, so let's start. Neuropathic pain and sensory ganglia. So the first few things to keep in mind. Number one, the definitions of various neuronal tissue structures or collections. In our brain and our brain stem and our spinal cord. So brain, brain stem, spinal cord, they all make collectively central nervous system. There are collections of neuron cell bodies. So the we have a neuron is a cell body, then it has a long axon, then it has many tiny branches that are called dendrites. So these dendrites and axons together are called neurites. Here, the this sheet of the gray looking sheet here, this contains the neuron cell bodies. Of course, the dendrites are tiny branches, so they are also there. And dendrites make interconnections, so those interconnections are there as well. And then there are small microscopic tiny neurons that are just really very small, and they connect two neurons together. They are present here as well. So this part, which makes a sheet of neuronal cell bodies, is called gray matter. It is called gray matter. Now, of course, from these neuronal cell bodies, the axons will emerge. Either they will be going into them or they will be coming out of them. So these axons together make big parts of the brain. And when we look at them under a microscope, they look white because majority of these axons are myelinated. That is a cell that is wrapping around them. That myelin under the microscope looks white. So we have gray matter, which is a collection of neuron cell bodies making a sheet in the brain, cerebellum, spinal cord. This is the gray matter in the spinal cord. Now, there is another definition or another structure of neurons, and that is neurons here, for example, can be interspersed with white matter, that is, passing neuron axons or the threads, and interspersed in those threads are neuronal cell bodies as well. So when you look at these under a microscope, they look like a dotty appearing structure with the neuron cell bodies look darker and the white matter looks white. So that we say reticular formation. So scattered neurons in white matter is called reticular formation. Then outside the sheets of the gray matter, there are also clusters of neurons that are going to perform a single function. They can be sitting together as well deep in the brain. For example, here we see some clusters, and in the brain stem, these are called nuclei. So inside the central nervous system, we can have gray matter or reticular formation or nuclei. However, it is also possible that some of the neuron cell bodies are not sitting inside the central nervous system structure. That means these neuron cell bodies are not in the brain or brain stem or the spinal cord. Instead, they are sitting outside. So here we have a neuron cell body that is present outside of the central nervous system. This cell body has an axon. Actually, we say this is one axon, and that axon is split into two parts. One is called a peripheral part, and the other one is called a central part. This is a classic sensory neuron. So what is the takeaway over here? Neurons can be present, neuron cell bodies can be present outside of the central nervous system. And when they are present outside of the central nervous system, and when they make a collection outside, that would be called a ganglion. Now here we are looking at a sensory neuron with two parts, one part of its axon connecting somewhere with our tissue, for example, to skin or to muscle or bone or tendons. And the other part is connecting to the spinal cord. From the spinal cord will be called a central part for it. The next neurons will take the sensation to brain, to thalamus, and then from there to brain. Now this neuron out here is called a pseudo-unipolar neuron because it has a single pole coming out of it, which then divides into two. And we thought that these are actually two axons, but really this is one pole with two parts in it. So we call it false one pole. The neuronal cell body will be called a soma. Soma is simply body. And then we have two parts of the axons. So I would like us to keep this structure in mind, because throughout this whole discussion, we're going to keep talking about this neuron. The peripheral part will have some receptors on it, which are, for example, receptors for touch, pain, pressure, temperature, 2-point discrimination, where you can tell if the doctor is touching 2 points and that is 2 or 1 point, so that is called 2-point discrimination. It's not necessary the doctor does it. You can do it as well. If you touch 2 points closely enough and close your eyes, can you tell these are 2 points or one? That is called 2-point discrimination. It's a sensation as well. And then vibration and proprioception. Vibration is a sense of vibration. Proprioception is the sense of knowing where our body parts are. Good. Now, before we continue, the definition of neuropathic pain. Pain is an unpleasant sensation. Always has to be unpleasant. Pain is also subjective. When a patient says, I have pain, you have to agree that they have pain. You cannot dismiss it to say you don't have pain if a patient is saying, I have pain. It's a subjective emotion. However, neuropathic pain is slightly different. Neuropathic pain occurs when the actual pain receptors are not firing. For example, if you crush my finger, the pain receptors over here will start firing, and that would produce pain. That is not neuropathic pain, although it is using the pain nerves. Neuropathic pain is when pain occurs because of some damage or some lesion, as we call it in medicine, of the somatosensory nervous tissue. So there is no crushing injury somewhere, but there is some problem with the nervous tissue, which is then causing the sensation of pain. So here, the International Association of Study of Pain, or IASP's definition of pain is, neuropathic pain is, pain caused by a lesion or disease of the somatosensory nervous system. Somatosensory simply means, soma means our body, and sensory is the sensory system. Now, body is divided, for these definitions, divided into two major chunks. Those parts that we can control, for example, our muscles, bones, tendons, and those that we cannot control. Interestingly, skin, although we cannot make the skin move, but skin is also part of somatic sensory system. The other system is visceral system, which is taking the pain sensations from, let's say, liver and spleen and heart and lungs, etc. So here we are talking about somatosensory system. Lesion or disease of somatosensory system. That means it's not about something has crushed and there is a pain receptor that is firing. Now, with this in mind, let's start our sensory ganglion problem. So these are my sketches. I wanted to do a different way of teaching today. So here we have a sensory ganglion. A ganglion is the collection of neuronal cell bodies outside of the central nervous system. Sensory neurons, as I said, their bodies are present outside. When they are collectively present together, they will be called a ganglion. It's a collection of nerve cell bodies. Similarly, we have autonomic ganglions. For example, sympathetic ganglions have sympathetic fibers and their sympathetic neuronal cell bodies present in them. Ganglion has to be outside of the central nervous system. If there is any neuronal cell body that is within the central nervous system, for example, brain stem, spinal cord, then it will be called a gray matter or reticular formation or a nucleus. But if it is present outside and it makes a cluster, and those collection of neuronal cell bodies will be called a ganglion. So we're going to talk about a sad ganglion today. So before we understand how this ganglion can become pathological or sad, let's look at some blood supply related pointers. In our body, of course, we have the blood supply or the arteries that are coming out of heart, and then they would start dividing into smaller and smaller and smaller branches, and they'll go to the every part of our body. The blood vessels, when they reach various tissues, they divide and divide to become microscopically small, and they have a typical capillary, for example, the smallest blood vessel, has the structure that there are endothelial cells. Endothelial cells are nothing but the cells that are making up the walls of the blood vessels, inner walls. So this is an endothelial cell, this is another endothelial cell. And if you see here, between the cells, there are very tiny, very narrow, microscopic gaps. These gaps allow the gases to be exchanged, glucose to come out, other nutritional substances to come out or get back into the blood vessel. So there are gaps between the endothelial cells. This is a typical blood vessel, capillary. Now, in the case of brain, and I have a reason for discussing this because we're going to talk about the blood supply of the sensory ganglion. In case of the brain, our body has not trusted that the substances present in the circulation should come in contact with the brain tissue, neurons in the brain. So there is a very good, very robust protection in the form of blood-brain barrier. In a high level, blood-brain barrier, so if you look at this capillary, for example, in the brain, first difference you would see from this one is that there are no gaps between the cells. So the endothelial cells of the blood-brain barrier capillaries, they are tightly pressed against each other and they obliterate the junctions between them, or we call these as tight junctions. So number one, these cells have tight junctions. Because they have tight junction, nothing from the blood can actually come out. So then the question will become, how do things come out of the blood, for example, glucose or other substances? There are special channels that would allow things to come out. This is to protect unwanted substances or macromolecules to come out or spill in the blood, in the brain. But this is not enough. Our body says, well, this is good design, but not enough. Then what we do is we have another set of cells that cover this inner layer. These other cells are called pericytes. So there is an internal tight continuous wall of cells. Then they are wrapped around by another set of cells called pericytes. So when something from the blood circulation is moved out through the channels I just described, that something, let's say it is glucose, they cannot still get into the brain. They would end up between the space of the endothelium and pericyte. So then pericytes also have channels in them, and this is the double checking part of it. Then the pericyte would decide, should this thing go to the brain? But our body is still not comfortable. We say, you know what, not happy with this. We need to have even more protection. So then we have another set of cells in the brain called astrocytes. They're called astrocytes because they have branches on them, and these cells look like stars. These branches have swollen ends. We call them foot processes or end foots or end feet. These foot processes of astrocyte also wrap around the pericytes. So now we have three layers of protection. The endothelial layer with tight junctions, pericytes around that, and then foot processes of astrocytes around them. And even then, when the substances are brought out, they are brought out through specific channels that would decide what goes out and what does not. Even then, the body is not happy enough. Body would also then put a lot of glial cells here and lot of monocytes here to make sure that if anything wrong comes out, it is quickly picked up and taken care of. Why did I discuss this? I wanted to present to you how careful our body is that substances from blood should not come in contact with our neuronal cell bodies. So we have blood-brain barrier. There are lots more complexities. I've done detailed discussions. This is just an overview. Now, let's look at another kind of blood capillary. There are actually three types of blood capillaries. There are typical capillaries. Then there are this one that I'm showing you here called fenestrated, and I'll explain that in a second. Then there is also another one with more sinusoids in it. For example, capillaries in the liver and spleen have sinusoids in them. But here, if you see, this capillary has another interesting thing. These are the endothelial cells. Endothelial cells are the cells that are making the walls, inner walls of the capillaries. Do you see that they have these little tiny holes in them? These capillaries are called fenestrated capillaries. They have holes in them to make sure that more of the substances from within the circulation can get out. Nothing just from the gap, these junctions, these gaps, but instead we have holes as well to allow bigger molecules. Although in my diagram here, the gaps between the cells look bigger than the holes, but these gaps are actually smaller and the holes are bigger, and they allow a lot of more things to be able to come out. This is called fenestrated blood vessel or capillary. And then, as I said, there are sinusoidal as well. So one more concept to wrap our mind around. Would you agree that a capillary that is a typical capillary doesn't have these holes in it that would allow less kind of substances to come out compared to a capillary whose cells have big holes in them? These fenestrations, these holes would allow macromolecules, these would allow neurotransmitters, these would allow drugs, bigger molecules, toxins to spill out of the blood vessel, of the capillary. Would you agree? Now, keep this one in mind, because this is the one that is present in sensory ganglion. The whole brain, central nervous system, is protected with the blood-brain barrier, but the poor sensory ganglion is not. Instead, it is not even protected with typical normal capillary. Instead, it has fenestrated capillaries. So we're going to talk about that. So here, now we're going to develop a sensory ganglion. The sensory ganglion is a collection of nerve cell bodies. So here we have one nerve cell body. This is another neuron cell body. This is another neuron. This is another. This is another. And these neurons have their peripheral and central processes. Every sensory nerve is actually connected to the tissue somewhere and then goes towards the spinal cord. So here is a collection of neuron cell bodies. When I said before that neuron cell body collection outside of the central nervous system is called a sensory, a ganglion, not sensory. There are sympathetic ganglions too, parasympathetics too. So a ganglion. So you might say, okay, fine. we now see the structure, all good, but not enough. Now, if you see, I have added here another set of cells, these little darker cells. And I hope you like these diagrams, a little more sketchy and artistic. So here we have the neuron cell bodies, and these neuron cell bodies are surrounded, covered by another set of cells called glial cells. Glial cells are support cells. They are stem cell-like cells. In the sensory neuron, in the sensory ganglion, these cells are called bipotent cells. Very important point here. They can replenish themselves. That is one potency of them. That is one feature of them. That is one capability of them. And they can give rise to new sensory nerves. That is their second potency. That is their second capability. This is why they're called bipotent, two potencies. This second potency is actually sometimes detrimental for the patients, because when sensory ganglion is under stress or injured, and the glial cells in their wisdom try to make more sensory neurons, they might actually make incorrect sensory neurons that would get incorrect connections, producing chronic pain that cannot be resolved. So glial cells are here. Important thing to note in the context of sensory ganglion pathology is that these glial cells, instead of successfully surrounding all the neurons and providing them protection, they actually intentionally leave gaps between them to leave the neurons open for other substances from the microenvironment of here to come in contact with the neuron. Glial cells in the sensory ganglion or other ganglions are called satellite glial cells. They partially surround the neurons instead of completely surrounding them. They leave gaps between them. Okay? Continuing to build the sensory ganglion together. Next step. Now, if you see here, we had the neuron in there, then we had the glial cells, these gray ones, and now I have made some more cells over here, these angry ones. They are macrophages. Sensory ganglions do not have B cells or T cells or dendritic cells, but they do have macrophages. These macrophages can be useful or hurtful. If these get triggered by the inflammatory molecules present in the circulation, these macrophages can become activated and release inflammatory molecules that can hurt or trigger the neurons, producing the feeling of paresthesias and pins and needles and burning sensations. And because sensory ganglions are present for every part of our body, when there is inflammatory molecule present in our circulation that enters the sensory ganglion and triggers the macrophages or directly comes in contact with the neuronal cell bodies, that would create paresthesias and pins and needles throughout the body. So now we have macrophages as well, and we have neurons that are sitting out in the open. The protectors of the neurons are actually leaving gaps between them, the glial cells. Okay, so the story is still not done. Now I have one more blood vessel, just an illustration of the blood vessel. Of course, these are capillaries. These will be microscopically small branches of the blood vessels over here. I just made one as a representation. The blood vessels in the sensory ganglion are fenestrated capillaries. That means these things have huge holes in them to allow the substances from the blood to spill out in this little chamber. And these products, inflammatory products from the blood, toxins from the blood, drugs in the blood, hormones, neurotransmitters, and of course, beneficial glucose and other products. Macromolecules can spill out here. Not only if these are inflammatory, not only they can trigger the macrophages, which in turn can cause local inflammation, causing problems with the neurons, causing paresthesias and pins and needles and burning sensations. But these products can directly go and attach or interact with the neurons because these darn glial cells have left spaces open so that the microenvironment of this chamber can directly interact with the neurons. So circulating toxic substances, circulating inflammatory molecules that may not be able to reach the brain because of the blood-brain barrier and brain neurons are protected, those can actually reach the sensory neurons and cause triggering or damage of the sensory neurons. Now, I have to be fair to these macrophages because they may be saying that sorry about this software issue. So I have to be fair to these macrophages. These macrophages can actually convert to M2 type, which are anti-inflammatory macrophages. Sometimes when sensory ganglion has inflammation in it, macrophages can become converted to M2 and try to reduce inflammation and try to support the neurons and protect them from dying. However, They can also be M1, which are inflammatory, and that would then cause local inflammation. So I hope this much is clear. The structure and the functional or operational behavior of the sensory ganglions and how their microenvironment is designed to interact with the neurons. Maybe, now this is my commentary, everything else is from the evidences that I have shown you before. This is my commentary that maybe this design is kept so that if there is anything wrong happening in the body, if there is inflammatory molecules or if there are drugs, bad drugs or toxins, they can reach the neuron, sensory neurons, and cause them to be triggered, which would then cause throughout our body this feeling of burning sensations and paresthesias and pins and needles and allodynia, etc., to alert us that something wrong is happening. But that's just my theory. I may be wrong. Okay, so I hope that this structure is clear. In this structure, we have neurons, we have fenestrated capillaries, we have glial cells, and we have macrophages. Now, I wanted to show you the evidence for this as well. So here is a writing about the structure that I just discussed. The sheath formed by satellite glia surrounding the sensory neuron cell body, but is not continuous. Rather, it contains interspersed gaps that allow the penetration of dye tracers, neurotransmitters, and other macromolecules. Similarly, sensory ganglia blood vessels are lined by a mixture of continuous and fenestrated endothelium that also allows extravasation of dye tracers and macromolecules. As a consequence, unlike central nervous system neurons that sit within the blood-brain barrier, sensory neuron cell bodies lack a barrier to the circulation. These structural features make it likely that sensory neurons are readily exposed to inflammatory mediators, systemic drugs, toxins in the circulation, perhaps more so than many other organs in the body. So then the question is, so what? Okay, sensory ganglion and neurons seem to be by design more exposed to the circulatory issues. Here is the problem. Now I have taken out one neuron, one sensory neuron from the ganglion. This could be autonomic as well. This could be sympathetic as well. We know that the patients of SARS-CoV-2, for example, or vaccine, they can develop autonomic problems. And we can look at circulatory system, but the evidences and the studies that I would share with you, which are in the description of this video, you would see that there are, instead of looking at the blood circulation and endothelial problems, it could be sensory or autonomic autonomic ganglionic problems. So here, let's use one neuron. This is a neuron. It somehow became damaged. Either it became damaged because its peripheral nerve became damaged, or it became damaged, for example, because of diabetes, or it became damaged because of other kind of substances present in the blood circulation that have come in contact, as I discussed before. I want to go to the next step, that what happens. So here is a neuron connected to the periphery and to the center, right? We did this before. Now check this out. When a sensory neuron, the cell body, is under stress, it can start producing ectopic signals. It can start producing ectopic signals. Ectopic signal mean a signal produced from where it should not be. And what do we mean by that? Look, a nerve signal, especially sensory nerve signal, should start from a receptor. For example, if you touch your finger, that is where the receptor is, from where the nerve signal would start and travel all the way back to the spinal cord and to the sensory ganglion, from the before the spinal cord to the sensory ganglion to the spinal cord and then to the brain. So signals start from receptors. Then they travel towards the neuron cell body. They don't touch the cell body. They just travel and then continue to their central part. Then they'll go to the spinal cord, and then the second order will go to the brain. However, if this neuron cell body started creating signals, we will call them ectopic signals. Ectopic signals can go towards the periphery. This is a problem. It should not happen that in a sensory nerve, the signal goes from the neuron cell body towards the periphery. This should not happen. Signal should come from the periphery to the center. But here, because it is produced here, it's going to go towards periphery. That is one. And it is also going to go towards center. So simultaneously, one to the center, one to the periphery. You say, okay, so what? Fine. Here is the problem. The signal that went to the periphery, it reached the nerve cell receptors. For example, we have Pacinian corpuscles, we have Merkel's discs, we have spindles, muscle spindles, etc. But for example, pain nerves, we have free nerve endings. Now remember, we're talking about sensory neuron. It's not necessarily pain neuron, but the sensory ganglion has pain neurons passing through it, and touch neuron passing through it, and pressure neurons, and vibration, and two-point discrimination, and proprioception. They're all collectively passing through this. Imagine this was a pain neuron whose cell body got triggered. And when the stimulus went to the periphery, it is called centrifugal travel. The pain nerve ending, free nerve ending, will produce or release chemical substances called substance P and CGRP, which is calcitonin gene-related peptide. So I hope I'm making this clear that number one, this signal should not have gone this way. Number two, if it has gone this way, it can have a detrimental effect because the neuron cell ending, the free nerve ending, under the influence of the signal coming towards it, will release substance P and CGRP. So then the question is, why does that matter? Here is why this matters. Substance P, for example, causes, now before I discuss this, let's agree on this, that there was actually no problem here. So let's say this was a joint, or this area was a muscle, or this was part of skin or hand or toes or something. It was a normal, regular, healthy tissue. But its nerve has started releasing substance P and CGRP. The substance P and CGRP will do the following. Number one, it causes local inflammatory cells to become activated, especially substance P. So the natural killer cells, the macrophages, dendritic cells, they can become activated. When they will become, put a macrophage over here, pour substance P on it. This macrophage is going to become active. When it will become active, it would actually start the process of inflammation here. It would actually start releasing even more cytokines and chemokines. It would actually call a lot of more immune cells to the vicinity to say, hey, we have a war going on, while there was actually no problem here. And all of a sudden, the patient is going to feel pain and inflammation in this area. And if it is a sensory ganglion, one sensory ganglion involved means all of them involved. That means this pain and swelling and inflammation is going to happen everywhere in the body. Every joint, every muscle, every part of skin will become involved. So substance P and CGRP, they cause cell growth, substance P especially, proliferation, meaning increasing in number of cells, angiogenesis, new blood vessel formation, which we do not want. This was a healthy area. Migration of other immune system cells to come in here, migration of angiogenic cells, the blood vessel making cells. Then it will help produce with the CGRP, vasodilatation in the local area. The way we produce inflammation in various tissues is that we dilate the blood vessels. That brings more blood in that area. That also lets more immune cells to come to that area. Plus, the endothelial cells kind of separate a little under the pressure of the relaxation, the dilatation of the blood vessel, and more substances and fluids start spilling out. So that area starts becoming filled with extravasated molecules and fluids that are coming out of the blood vessels, which are dilated, and the immune cells are going to start migrating and entering here and start causing inflammation. They don't know that there is no issue over here. They would just start creating inflammation. So the patient's tissue will become inflamed, swollen, red, painful. If it is joint, it would have joint pains. If it is muscle, it would have muscle fatigue and muscle pains and exhaustions. If it is skin, then all those things I said before, blotty skin, red, blue skin, marbled appearance skin, dry skin, etc. And here is the problem, second problem. This local inflammation that started here unnecessarily will cause the local cells and the immune cells to start releasing new chemokines and cytokines that would act on these nerves to cause the signals of pain to start going as well. So we are now stuck in a loop. This cell is sending signals, result is local inflammation, which is sending again signals back. But in this whole thing, we haven't said that this will cause paresthesias, although you can see that when inflammation would occur here, that would trigger these cells. But there is another problem, and that's the last topic, I promise. The other problem is that this neuron, sensory neuron, that was sending centrifugal impulses towards the periphery is also sending centripetal impulses too. Impulses generated here would travel in both directions. When it goes to the spinal cord, it will just feel like this sensory neuron is firing, which will mean that when that sense would go to the brain, when that signal would go to the brain, then whatever this sensory neuron is, and for whatever tissue, we will feel something in that tissue. So paresthesias would occur. Paresthesia is abnormal sensation. Nobody is touching a part of the body and we feel there is a touch. There is burning sensation. There is pins and needles. There is hot and cold, while there is no problem in that area. So not only this neuron is causing peripheral problems, it is actually sending signals, wrong signals, to the brain as well, and now brain is feeling them. So this is how if this ganglion was autonomic ganglion, sympathetic, parasympathetic, then autonomic system will start misfiring. Palpitations could occur, incorrect visceral movement, for example, GIT, incorrect secretions of the viscera, incorrect controls of the urinary system, reproductive system, etc. Whatever sympathetic system and parasympathetic do, these can become malfunctioned. Our first noticing is when the cardiac palpitations and blood pressure changes are observed. Now, that doesn't mean that there can be no stress to the heart. There may be stress to the heart and the blood vessels, but sensory and or autonomic ganglionic problems can cause paresthesias, which is incorrect sensation. Allodynia is a sensation that is increased to pain. For example, if you touch your finger, it should not cause pain. But if you touch it and it starts giving you the feeling of pain, it may be either a local damage or the sensory neuron damage, maybe in the ganglion. That is allodynia. Hyposthesia, reduced pains. So this is the discussion. I wanted to bring this to surface for all of us, that sometimes it's not necessary that the effect we are seeing in the body is just vascular problem. It could be a ganglionic problem as well. So with this, thank you very much. My apologies, this is a new system, so I kind of got lost a couple of times in it. And initial audio, I will edit that out and fix it. It usually takes a few hours to do that. In the meantime, if you would like to support this work, I am not supported by any pharmacy or any other organizations. This is my work, and this work is only supported by either YouTube ads or if you buy Dr. Bean courses. That's how I'm supported. That's how I pay my bills. So if you would like to support this work, either become a member on drbeen.com or just like, subscribe, and share as well. So thank you very much. If you liked this one and if you would like to have more discussions of neuropathic pain and the management interventions, let me know and I would then do them as well. Thank you and have a good night.